on the clinical guidelines of adult Refsum disease. These guidelines mark a significant advancement in the management of adult Refsum disease, providing clinicians and patients with much needed guidance to improve care and quality of life. I'm personally very excited about this. I am Christy DeMarco. I'm the founder and president of Global DARE Foundation, and I'll be your host today. We're honored to have Dr. Radha Ramachandran, who is a consultant in the metabolic medicine and adult inherited metabolic diseases clinic at Guy's and St. Thomas NIHR Foundation Trust in London, where she serves as the clinical lead for that service. She completed her specialist training at the Imperial College Healthcare NIH Trust and the National Hospital of Neurology and Neurosurgery, with a focus on adult inherited metabolic diseases. Awarded the prestigious NIHR Doctoral Fellowship, Dr. Ramachandran's research centers on biomarkers for neuroendocrine disease. She has been instrumental in the care of adult Refsum disease patients since 2014 and currently leads the Refsum Center of Excellence, which houses the UK's largest cohort of adult Refsum disease patients. She also serves as a member of Global DARE Foundation's Medical and Scientific Advisory Board. Now on to, let's see if I can flip the page here. Yeah, now on to our mission at Global DARE Foundation. Global DARE Foundation was actually established exactly 5 years ago in October of 2019. And DARE stands for Defeat Adult Refsum Everywhere. Our mission is to promote worldwide awareness and better quality of life for those that are diagnosed with adult Refsum disease. Our goal is to support research, education initiatives, awareness campaigns, and advocacy. Together with our Medical and Scientific Advisory Board, driving research is at the center of what we do because we dare to believe that there is a cure for adult Refsum disease. Now on to some housekeeping details. All of the participants are in listen-only mode without video. You can type your questions during the presentation by Dr. Ramachandran in the right-hand side of in the Q&A box on the right-hand side of the screen. It won't be possible during the presentation or after the presentation to unmute yourself to ask your questions verbally. After the presentation, we will open it up to questions, and then I'll be moderating those questions. Today's session will also be recorded for later viewing on the Global DARE Foundation's YouTube channel and website. So I'll stop sharing now and turn over the presentation to Dr. Ramachandran, where she'll go over the clinical guidelines. But you'll need to take yourself off mute.
Thank you, Christy and Susan, for giving me this opportunity to discuss some of the aspects of clinical management. I hope that later on in the year it'll come out as a presentation, but for now I'm just going to go through the main aspects of clinical management of patients with Refsum disease. I'm just going to start off by sharing my screen so that you can see my presentation. So hopefully you can see the presentation. Are you able to see it? Brilliant. Excellent. So as Christy said, I work at Guy's and St. Thomas's Hospital, and within the hospital I lead the Center for the Inherited Metabolic Diseases. So inherited metabolic diseases, I thought I'd just give a little bit of an overview. It's a group of diseases that are genetic diseases, and they cause dysfunction of one or more metabolic pathways. At the moment, there is an international classification of inherited metabolic diseases, and this number keeps growing every year when new conditions get discovered, and we are presently at 1,462 entries in this group of disorders. Adult Refsum sits within this group of disorders. We have more than 1,000 patients with various inherited metabolic diseases seen at our center. And the center has a core team with 2 consultants, 4 dietitians, 1 dietetic assistant, clinical nurse specialist, pharmacist, and admin support teams. We're also co-located within a large hospital that offers acute services, and therefore we have most of the major specialties that we would need to consult when we're managing patients with adult Refsum disease. As you know, the clinic actually was first located in Chelsea and Westminster Hospital. It was run by Professor Gibbard, who did a lot of the pioneering work around the management of patients with Refsum disease. You can see a picture of the old Chelsea and Westminster Hospital over there. And also at this point, I'd like to mention Professor Mike Fair, Professor Tony Musbeki, and of course, Eleanor Baldwin, who many of you listening to this presentation will know, and who have over the years looked after most of our patients with Refsum disease and done a lot of work towards improving the management and care of people with Refsum. But when the Adult Inherited Metabolic Diseases Center was set up at Guy's and St. Thomas's, it was felt more appropriate that patients moved to this center so that they're looked after within the umbrella of this hospital, because a number of the principles of management of patients with adult Refsum disease are actually quite similar to a number of other conditions that are managed within the center. So that said, adult Refsum disease, as you know, is an ultra-rare disease. It's a rare disease amongst rare diseases, and we think that the prevalence is around 1 in a million. We have 27 active patients regularly under review at Guy's and St. Thomas's, and that number is probably the highest anywhere in the world. So it just gives you an indication of how rare the condition is, or at least how few the number of people who are diagnosed with this condition is. The patients in the clinic are seen in a separate clinic. As you know, the NHS is free to patients, and therefore all patients are seen free, and we work within the constraints of NHS. We schedule the clinic early in the afternoon so as to ensure that there is some light, at least, both during summer and winter times. Travel expenses are reimbursed for our patients. We have done some modifications to the clinic arrangement so that it's on the ground floor with easy access to blood rooms, particularly important for our visually impaired patients. And we also share care with a number of other specialist hospitals, such as the Moorfields Eye Hospital, where a number of our patients get seen for their eye disease. So the clinical presentation, I'm going to be very brief, as most of you listening to this are going to be aware. So I'm going to start with bony abnormalities because possibly present at the time of birth, although it is not always apparent at the time of birth, and probably becomes more obvious in the early teens or towards adulthood. Most patients will present to the clinic for the first time with problems with vision. So retinitis pigmentosa, it is almost always present in patients. Out of the 27 patients in our clinic, 26 have retinitis pigmentosa, and that would be their first contact with the medical team, at least so far as Refsum disease goes. A number of patients also know that they have a loss of sense of smell, hearing loss, some degree of neuropathy, skin problems such as itching and dry skin, and occasionally impaired kidney function as well. So how do we diagnose Refsum disease? As I said, the first contact is probably in the eye department with retinitis pigmentosa. And also at that point, if the ophthalmologists carry out a further clinical examination, then sometimes the bony abnormalities such as the shortened fourth metatarsal or the shortened fourth metacarpal are obvious, and that might alert an ophthalmologist to thinking about adult Refsum disease. At this point, it's important to say that these bony abnormalities are only present in between 30 to 50% of patients, and therefore anyone with retinitis pigmentosa should be assessed for the presence of Refsum disease, particularly because it's a treatable condition. So physician awareness is important, and I have to say that over the years that has improved greatly. And so once Refsum disease is suspected, we would measure photonic acid levels in the blood. Traditionally, the teaching was that the photonic acid levels in the blood are significantly higher than in the reference population, and therefore 50 to 100 times higher usually. However, more recently, we have realized that this is not always the case, and people with Refsum disease can present with normal or nearly normal levels of photonic acid. Therefore, genetic testing to confirm Refsum disease, particularly in patients presenting with retinitis pigmentosa, is very important. And this is, of course, becoming more commonplace, particularly because in a number of centers, patients presenting with retinopathy or neuropathy or a suspected inherited metabolic disease would almost always have gene panels, which would include, certainly in the UK, genetics for Refsums. And therefore, we have noticed that the diagnosis of Refsums, wherein before there would be a lag of 10 to 12 years between the first presentation with retinitis pigmentosa and diagnosis of Refsum disease, that lag in diagnosis has decreased and will hopefully decrease further with the much wider availability of genetic testing and increased physician awareness. So once the diagnosis is made, how do we manage patients with Refsum disease? The main idea or the main principle of management is lowering photonic acid levels. And the reason we want the photonic acid levels to be lowered is because the consensus is that this may slow the progression of eye disease and prevent some of the neurological sequelae of Refsum disease. And it definitely does prevent acute decompensation when the levels of photonic acid are lowered. So how do we lower the photonic acid? Photonic acid, as we know, is mainly available through food, i.e. the body is unable to synthesize photonic acid, and therefore the treatment is by limiting photonic acid intake to less than 10 milligrams per day. I'm not going to go into details of the dietary management of Refsum disease because I know that there's some very good presentations and very good material on the Global Dare website that people can refer to. I think it's suffice to say that the data on foods is limited, but Global Dare has done some excellent work by funding research into the levels of photonic acid in foods, and this has guided the new guidance on dietary management of Refsum disease. I think there's a word of caution here to say that there are some things that have changed in the dietary recommendation over the years, and it is possible that that will evolve in the future as new data becomes available. In addition to providing advice regarding diet or foods that are low in photonic acid and therefore foods that are allowed and not allowed in Refsum disease, the other aspects of nutritional review would be in every clinic our dietitians would take a detailed dietary history to ensure compliance with the diet and also ensure understanding of the diet. In addition to that, it is important that the diet is balanced because patients with Refsums are just as vulnerable to other metabolic diseases such as diabetes or obesity or heart disease, and therefore it's important that within the constraints of the low photonic acid diet, we should ensure that the diet is balanced as far as possible. It's important to ensure that there are adequate calories that are taken to keep the weight stable. We will go into more detail later on, but we do worry about sudden weight loss because that can increase the risk of acute metabolic decompensation. Also, any condition where we advise strict dietary restrictions, and we advise people to avoid different food groups. We worry about micronutrient deficiencies, and therefore we would measure their vitamin and mineral status on a regular basis to ensure that they are sufficient in all the important micronutrients. And in every clinic appointment, we would monitor for modifiable risks for acute decompensations, such as any weight loss or any other intercurrent illnesses and comorbidities that might increase the risk of weight loss or increase the metabolic rate and cause higher phytanic acid levels. So for that reason, we would measure a lot of other parameters, which I will come to in the next few slides. One of the questions that patients who come to our clinic often ask us is about exercise and weight loss. Obviously, there's an increased awareness of maintaining a healthy lifestyle, and that would include exercise and sort of maintaining an ideal body weight. So this is something that we would advise all patients with Refsum disease to discuss with their dietitians and physicians, and also to ensure that any exercise or weight loss that is undertaken under close guidance of dietitians and physicians. If patients have a higher baseline of phytanic acid level at greater than 200 micromoles per liter, then we are more cautious about how we advise with regards to exercise and weight loss, because what we're trying to do here is ensuring that our patients are able to exercise and lose weight, but in a way that prevents acute decompensation or rapid phytanic acid rise. So if weight loss is what we are aiming for, then we would advise very, very gradual weight loss. We may ask patients to stop losing weight to keep their weight stable, or maybe even put on a little bit of weight if their phytanic acid levels are very high, because any weight loss will result in further increases in phytanic acid levels. So we may ask them for a period of time to keep their weight stable until their phytanic acid levels fall, and then we would give them a go ahead to lose the weight very gradually. Very similarly, exercise as well. We advise very gradual build up of exercise, ensuring that they've got enough calories so that they're not relying too much on the breakdown of fat, which would automatically increase the levels of phytanic acid circulating in the blood. And if we are putting our patients through a guided exercise or weight loss program, then we will be monitoring their phytanic acid levels a lot more closely to make sure that there are no rapid rises. So how often do we monitor phytanic acid? Traditionally, we would see our patients once every 6 months. We have more recently started to offer video appointments, and therefore measuring phytanic acid in clinic is a little bit more difficult, although we have increasingly tried to have them measured remotely and the results sent to us. So I would recommend phytanic acid levels 6 monthly or annually, particularly if the phytanic acid levels are very nicely controlled and less than 200 micromoles per liter. Obviously, if they are higher or if they are likely to impact management, for example, before giving weight loss advice or exercise advice, or if our patients have intercurrent illnesses that may impact on their levels, then we would want to measure it a bit more often than that. And sometimes we may ask to measure it on a monthly basis. Or if they're admitted with very high levels and acute symptoms and they are in hospital, we might actually measure it 1 or 2 times a week, particularly if we're actively managing those levels. So what other tests do we do when patients come to clinic? The main manifestations, other than the eye disease that we look out for, are the neurological manifestations. So a number of our patients might have motor or sensory neuropathy, and by that I mean that they might have problems or weakened sort of sensory perception in their legs, or they might have a bit of weakness or problems with their balance. And so we would monitor for that. We do a baseline nerve conduction study and brain MRI for most of our patients, particularly when they come into the clinic for the first time or if they haven't had it for many years. And then review the symptoms on an annual basis, and any other testing would depend on the symptoms. So we would check for neurology, as I've already discussed. We would review their symptoms, the eye symptoms. Most of our patients are under a regular review by eye clinics, and we would be guided by our ophthalmology colleagues in terms of management for cataracts or for visual impairment. Hearing, about 50% of patients with Refsum disease have some degree of hearing loss, and this is usually again dependent on symptoms. And in the UK, most of our patients are able to access hearing tests in the high street, and we would advise them to do so. In addition to that, we would carry out some blood work as well, and we check for conditions like diabetes and thyroid disease, particularly because it has an impact on metabolism, and therefore it's important for us to know if someone has these conditions, because that would have an impact on the phytanic acid levels. Similarly, kidney and liver functions are important for us to know. Cholesterol levels, again, because our patients, particularly our Refsum cohort here in the UK, are older and therefore at risk, as I said, of other metabolic conditions that are more common, and therefore we monitor for that as well. And also because we are dietary restricting them, we would measure the vitamin and mineral levels as well. We commonly measure the B vitamins and the A, D, E, and K vitamins, and also essential fatty acids and vitamin D. We would ask for any symptoms relating to their skin, so if there's any itchiness or any dry skin, and this usually is associated with higher phytanic acid levels. Bones, again, some of our patients do have bony abnormalities, particularly related to the short bones of the feet and the hands. Not many of our patients will have active ongoing problems, although a number of our patients, again, are in the older cohort of patients and are now reporting symptoms of arthritis and needing knee and hip replacements. The heart, usually not much of a problem unless in the acute setting and very high phytanic acid levels. But again, we would do a baseline echocardiogram and ECG. And as I said, particularly as our patients are getting older, again, they are just as much at risk of heart disease or common coronary artery disease like the rest of the general population, and that's important to bear in mind too. So this was just a slide I put up for cardiomyopathy, and I think the take-home message here is that most of our patients don't have any problems with the heart. Heart failure and abnormal heart rhythm is common in acute presentation related to really high phytanic acid levels reported at greater than 2000. And when patients come in with levels that high, then we would want them to be on a cardiac monitor for safety. So again, as I said, in terms of cardiac monitoring, we're doing symptom-based monitoring. We're monitoring active cardiac monitoring in the acute phase, and otherwise we would do a baseline echocardiogram and an ECG. So some of the other case reports, the odd ones that have been reported, are specific kidney disease where the kidney is leaky and is leaking important substances like proteins, some white matter changes in the brain, and sometimes one case report of a patient with vestibular neuropathy whereby there is dizziness related to the damage of the nerves in the ears that are related to balance. But none of our cohort of patients are known to have any of these. So the management of the comorbidities that are associated with Refsum disease, so for example, the neuropathy or the eye disease, etc. The management is supportive, just as we would for anybody else who has these symptoms and does not have Refsum disease. One of the things to remember, though, is that, for example, the cataract surgery in patients with Refsum disease is slightly more complicated and requires a bit more expertise in management because of the complications that can be associated with cataracts in patients with Refsum disease. We also offer all our patients an emergency regime, and the aim of this regime is to prevent a catabolic state that may lead to release of stored phytanic acid into the circulation. So what that means is that when the body is either got less calories than it's needing, then the body breaks down fat in order to use fats as an energy source, and in doing so it releases phytanic acid, which is stored in the fats, because that is where most of phytanic acid is stored, and this causes a rise in the blood phytanic acid levels and therefore may result in acute decompensation and complications. So the rationale for this regime is because we have other conditions where patients have problems with utilizing fats as an energy source, and so these patients are routinely offered an emergency regime. And so we thought that perhaps this might be appropriate for patients with Refsum disease as well. And this is further highlighted by this study where they looked at the metabolism of phytanic acid in patients with adult Refsum disease. And what they found was that the plasma phytanic acid doubling time is 29 hours. What that means is that if a patient is fasted, then the phytanic acid levels will double within 29 hours of fasting. We can't repeat this test nowadays. It would not be ethical for us to do so, but this was done a long time ago. And 5 patients with Refsum disease were fasted for 56 hours. And they found that one patient lost 8 kilos within that time. One patient remained unwell for up to 12 weeks, and another patient had severe leg cramps for 3 days after this fast. So looking at the phytanic acid doubling times, so if someone starts off with a phytanic acid of 200, then within fasting for slightly over a day, you would find that their phytanic acid will most likely go up to 400 or 500. Therefore, as you can imagine, higher the baseline phytanic acid, higher the risk of bringing the phytanic acid levels to dangerous levels. So what do we do in terms of the emergency regime? We advise our patients to take an oral glucose polymer. There are many different brands that are available. The one that we use in the UK commonly is the SOS 25. It has 25 percent glucose, and therefore any glucose polymer that provides a similar amount of glucose can be used, and the details are again on the Global Dare website. So our advice to our patients will be that if they're unwell, if they lose their appetite, and if they're unable to eat and drink normally, or if they've got vomiting and diarrhea, we would advise them to go on to the oral glucose polymer regime. And if they're unable to tolerate the oral regime, or if they are nil by mouth for whatever reason, then they will require hospital admission and intravenous glucose. And the glucose here is providing an energy source, again, so that the body is using the glucose as an energy source rather than breaking down fat and trying to use body fat as an energy source. So what we would also advise our patients is that if they are starting on an emergency regime, the metabolic team should be made aware that they are starting on it. Patients should not be on an emergency regime alone for more than 48 hours. And if they're not getting better or needing an emergency regime at 48 hours, then they may require admission and a more complete assessment and a nutritional plan. And also a very big caveat here is, again, a number of our reference patients are older and are diabetic or at risk of diabetes. And therefore, if they're unwell and if they are taking an emergency regime, it is really important that the metabolic team is aware. It is possible that because of their diabetes or risk of diabetes, the metabolic team may have tailored their emergency regime to ensure that they are not getting too much of a glucose load, or to ensure that they have means of testing their blood glucose, etc. So on that same principle, whenever people go for surgery, the usual practice is to ask patients to fast before surgery, often for about 6 to 8 hours. And therefore, any procedure that requires fasting, either before, after, or during the procedure, we would advise all patients to inform their metabolic team so that we could make a perioperative plan for them. And this generally involves good intravenous access, involves giving glucose solution until they're able to eat and drink normally, starting from the time that they are fasting, ensuring that their blood glucose levels are maintained, and ensuring that they are monitored for their electrolytes, for sodium, potassium levels, etc., to make sure that all of that is where it should be. And also to advise clinicians who are carrying out the surgery about the facilities that are important to have access to during the surgery, depending on what the surgery is. So, for example, for slightly major surgery, it might be important to have the surgery in a hospital that has access to cardiac monitoring or specialist dietetic teams or ITU facilities. So again, I just want to reiterate this as a caution, because obviously the emergency regime most of the time is a glucose solution. And so again, as I said, a number of our patients are significantly older than a number of other inherited metabolic conditions, and they might have comorbidities like diabetes and reactive hypoglycemia, and therefore one has to use this emergency regime with caution and under close guidance with the metabolic team. Also important to remember that if patients are getting pregnant or during labor, again, it is a time of metabolic stress, and therefore it is important that the metabolic team is aware so that they are able to make a birth plan and a plan for labor as well. Patients with Refsum disease, as you know, can also present acutely, and the acute presentation is usually worsening neuropathy. It is what we call a demyelinating kind of neuropathy, and usually presents with worsening of symptoms of numbness or difficulty walking, worsening of the balance. Sometimes patients can have a much more itchy or dry skin. And some patients have more recently reported symptoms such as worsening of their vision or brain fog. And as I mentioned earlier, if the levels of photonic acid are really high, 2000 usually or above, then there is a risk of cardiac failure or irregular heartbeat. So as soon as someone complains of symptoms that might be consistent with an acute worsening, then we would measure their photonic acid levels. And if their photonic acid levels are more than 1000, then we start to think about what else we need to do other than dietary advice. So we would admit patients who have got acute symptoms and levels more than 1000. We would immediately manage with the IV regime to give them some glucose so that they're not catabolic. We would carry out an inpatient nutritional review and advise catering staff in the hospital to ensure low photonic acid diet is available to our patients. We would have a low threshold for giving them feed by tube or through the veins if for some reason they are unable to eat and drink normally. Obviously, you have to look for intercurrent illness or reasons for why there's been a deterioration, and treat any other intercurrent illnesses. So for example, if it's a newly diagnosed diabetes, or if they've got infection, or if they've got thyroid disease, or whatever the intercurrent illness that's causing this problem, that will require to be treated. Any comorbidities need to be treated with supportive management, and that might involve things like physiotherapy or getting the occupational therapist to see if any modifications are required before patients go home. And also, if the levels are very high, we might admit them and in a bed or in a ward where continuous cardiac monitoring is possible. If the symptoms are worsening, and if there are cardiac symptoms, and if the photonic acid levels are more than 1,000 micromoles per liter, then we would consider plasmapheresis as an emergency management. And what that involves is plasma exchange. So a percentage or part of the patient's plasma is removed, and that would contain the photonic acid and then replaced with either albumin or donated plasma from another person. What normally happens with plasmapheresis is, is that the levels often rebound. So I'm going just to look at this graph. If you look at the squares here, they are the levels after plasma exchange. And if you look at the smaller dots here, they are the ones before plasma exchange. So as you can see that the levels rise, and then a plasma exchange happens, the levels drop, and then they rise again. And therefore, patients with refsums who come with high levels will require multiple multiple sessions of plasma exchange, 24 to 48 hours apart, a few times, in order to ultimately bring the levels down to a safe level. We in the UK only offer plasma exchange as in the acute setting. We do not offer it as a long-term management because there is no good evidence to suggest that it helps, and also there are risks associated with long-term plasma exchange. So the other question that we get asked is whether family members of patients with Refsum disease should be screened for Refsum disease, and the answer is absolutely. So all brothers and sisters of patients with Refsum disease should be screened, and usually we would take a family history and draw what we call a pedigree chart, so a family tree. And looking at the family tree, we will be able to work out which members of the family are at risk. And if there's consanguinity within the family, then that is slightly more complicated. And all at-risk family members should be screened for refsums, both with photonic acid and with genetics, so that the treatment can be instituted sooner rather than later. The other question we often get asked is whether it can be included or in the newborn screening. So currently, I'm not aware of anywhere that offers screening for adult Refsum disease in newborn screening. One of the problems is that the newborn screening these days is only done using blood markers or biochemistry, and photonic acid would be the obvious blood marker for adult Refsum disease. However, because photonic acid is only provided, or you can only get photonic acid through food, newborn babies are likely to have normal levels of photonic acid, and therefore it's not a reliable marker. It is possible that in the future, when there is advances in genetic screening for newborn babies, then maybe in the future it may be possible to include newborn screening for adult Refsum disease, but this is not currently available. I think I've come to the end of my talk there. I just want to thank all the patients in the Refsum's clinic, all my colleagues, Professor Wisbeki, Sarah Furman, Eleanor Baldwin, and the other dietitians who support our patients in the clinic, and also, of course, Global Dare for all the excellent work they've done towards raising the profile and also for progressing research in management of patients with Refsum disease. Going to end with that, and I'm happy to take any questions.
Thanks, Radha. If you want, you can stop sharing your screen. That way they can see us both up on the screen. Thank you. So I really appreciate, thank you very much, Dr. Ramachandran, for, very informative presentation. Obviously, Refsum is a very complicated disorder, and managing through all of that and explaining all of the things that are required is pretty significant. So I really appreciate you walking through it in detail in language we all can understand too. So that's not always easy when you're talking about complicated medical situations. So we do have, it looks like, one question. I would say anyone who has a question, feel free to go to the Q&A tab and put your question there. We do have one question so far. The question is there a limitation on the number of sleep hours due to the need to avoid long fasting?
I would say no, because the doubling time is 29 hours. And so we normally average sleeping times would be anywhere between 6 and 10 hours. And so within that time, even for our other fatty acid oxidation disorders, we would not be recommending waking up to have a snack or anything like that. No.
I appreciate that. That's not a recommendation. Sleep is so important, obviously.
Absolutely.
The other question that we have in here is, can a patient from abroad get treatment at Guy's in St. Thomas?
So the short answer is not, unless there's an arrangement with the hospital. So you could write to the hospital and ask them. And the second thing is that unless somebody, so a lot of the time it requires close dietary monitoring and repeated sort of blood levels and things. And we feel that that is best done by the local physicians who are there, who can sort of see patients more regularly if required. And also, if people are admitted with acute decompensations, it's actually quite nice to have a local team that has a degree of familiarity with the condition. So our preference would be, if there are any specific queries around management, then for the clinicians who are looking after the patients to get in touch with us directly, and we're very happy to advise or meet on Teams or provide that kind of support. And so that would be our preference. But if someone really does want to come to Guy's, then perhaps the thing to do is to write to the hospital directly and to see whether an arrangement can be made.
Great. I know that we've had several patients who have had their doctors consult with you or our Boston Center, which is very helpful, especially since Refsum is very rare. Even if there is a qualified dietitian, they might not, really know exactly how to manage with the Refsum diet, especially if there's comorbidities with diabetes. And, obviously there's some differences between those two diets and things. So it's great to have, that flexibility of at least having a consult piece with the physicians and dietitians. So great. Let's see, we've got another question. Let's see. If for some reason it's blocking my screen. Okay. If someone has been on a low photonic acid diet for years or even decades, why is there still a significant amount of PA available in the stores?
So the short answer is I'm not sure. But if we speculate, it really depends on when the diagnosis was made and what the diet was like before the diagnosis was made. So because the photonic acid gets stored in the adipose tissue, it can stay there for decades. And if there hasn't been necessarily anything that has caused lipolysis or caused the photonic acid to be released into the circulation, then it can sit there for decades to be released when there is sudden weight loss or if there's a catabolic state. So I think it has very much to do with what the diet has been previously, at what age the diagnosis was made, so at what how many years of photonic acid diet, not restricted, but unrestricted diet the patient was on. And also, I'm sure we're not able to definitely sort of define that, but I'm sure that the enzyme activity or the genetic mutation is not like an on-off switch. It impairs the function of the enzyme, but some people might have a slightly impaired enzyme and some people might have a more impaired enzyme. So perhaps that also probably plays part in how much phytanic acid accumulates and how much circulates.
Okay, thank you. Yeah, I'm often asked, what's a safe level of phthalic acid for a person with adult Refsum disease? Someone had recently mentioned to me that one of their physicians had said, well, no, if you have good compliance with the diet, you can get down to a normal level. I haven't heard that before, but maybe that is possible. I know plenty of adult Refsum patients, so it would get quite frustrated if they thought they could get down to a normal level with just good compliance. But what is your thoughts on that?
So we seem to have a few different groups of patients. We seem to have a group of patients who do get down to normal level. And then we've got a group of patients who sit between the 200 and the 400 mark. And then we've got a group of patients who, no matter what they do, the levels sit around the 6, 7, 800 mark. So we would feel comfortable if the levels are sort of around the 200-300 and below, because if you can imagine, sort of, if for whatever reason there's an illness or they haven't eaten very well for 24, 48 hours, and if you're thinking that the doubling time is 29 hours, then if they are sitting at around 200-300 and if their phytanic acid levels doubles, then they're still sort of within the okay range of 500-600. Whereas if their baseline is around 600-700 and they are ill and it doubles, then they're sort of getting into the territory of being over 1,000, and that's when we start to worry.
So what do you do when you said you have this cohort of patients who are in the higher range and there's nothing you do really gets them down into a lower range, even at doing maybe even plasmapheresis as well, right? You get obviously have the rebound effect associated with that too. Like what's the plan then when that happens?
When their levels are around the 600
Yeah,
mark.
or you said 600 to 800 even, like and they just can never get it down. Diet, managing metabolic stressors, plasmapheresis, they still just can't get it down.
Unfortunately, I think what we would do is to monitor it very carefully. We would be very careful about them not losing weight to keep their weight stable. We would be sort of much more cautious when they're unwell, in terms of whether they're maintaining adequate calories or not. Sometimes we have found in a couple of our patients that it was related to, although their calories might be adequate, sometimes not having enough carbohydrates within that calorie intake sometimes has an impact, and therefore increasing the carbohydrate proportion in their diet could be something that we would try. And I think beyond that, unfortunately, there aren't any drugs at the moment that we can sort of give. We haven't gone down the plasmapheresis route because we don't know, or there isn't any evidence to do that outside of the acute setting. So, and then also, if you look at the traffic light system, perhaps we would review the diet a bit more and try and tweak it. In a couple of our patients, we've been able to do that and bring it down from around 1,000 to sort of the between the 500 and 600 mark. But so much closer monitoring is what we would advocate.
Yeah, maybe there's something to think about from a research perspective in the future. The ones that have difficulty getting it down, like what's different about them versus the ones that are able to get to a normal. Is it genetic? Is there obviously lesser variants?
Possible.
Are there different types as you see? Maybe there's a different type of dietary. What's their makeup of their diet versus somebody else's? There could be a whole bunch of things we could do potentially from a study perspective, just to understand it a little more. There's a lot of unknowns. I'm sure as a physician that can be very challenging, managing through all the unknowns. So when people go through plasmapheresis and there's that rebound effect, is there a particular place normally where the PA is coming from that rebound effect? Is it from the liver, or is it even known?
We think that it equalizes. I mean, it's bit of the adipose, bit of the liver where it's stored, and we think it sort of there's a sort of equilibrium between the circulating and the stored phytanic acid, and we think that it's that equilibrium that sort of keeps bringing the levels of the circulating phytanic acid up, and it usually takes about 48 to 72 hours to sort of rebound and come up. And that's why when we're doing the plasmapheresis as well, it's important not to do it continuously, sort of, on consecutive days. We would sort of do it and then wait for 2 or 3 days and then repeat, to give it that time for the levels to rise again in the circulation.
Gotcha. Another question in the question box was, what is considered to be a good indication of positive decrease in PA levels following a diet?
You mean to say the level? I mean, so there is usually in the phytanic acid, if we were to measure it day to day in someone, there is what we call a biological variation of the phytanic acid, and we think it might be anywhere up to about 20%. And so normally what we would do is if we are sort of actively trying to reduce some of these phytanic acid levels, we would measure it more frequently, so maybe monthly or every 2 months. And what's more important is the trend. So a downward trend would be, so, rather than acting on individual levels. So even if we saw someone in clinic, for instance, and their levels are normally running around 400-500, and then we've done it and the level is about 1100 or 1200, we would sort of in the first instance repeat it, because just to make sure that that is a result that we should be believing, and then if it is still high, then, and if we are managing them, then we would repeat it consecutively, more frequently, and see a downward trend, and then that would sort of convince us that whatever we're doing is working to some extent.
Gotcha. In a question, a couple of people new to our community have come in who are younger. They were diagnosed earlier, and they seem to not have some of the other symptoms like maybe retinitis pigmentosa or hearing loss. They might only have bone abnormalities. Are you seeing some more of that as people get genetically tested now? Obviously, we're seeing people earlier maybe than you used to see. It used to take people 15, 20 years to get a diagnosis, after they already had RP diagnosed. Are you seeing some of that?
So the answer is yes and no, because normally the reason why somebody would present to, say, a clinic to get or if Refsum's disease would be considered in the differential would be RP. So we're certainly seeing patients who have got RP, who have been diagnosed with retinitis pigmentosa quite soon after they've had the diagnosis of RP. And therefore, although they have retinitis pigmentosa, they don't have the other comorbidities like the neuropathy, etc. And their levels are low as well. And they haven't developed in the last at least 5 or 6 years that we've seen them any other comorbidities. We do have one patient in our clinic who was diagnosed because their sibling had adult Refsum disease. And so they were diagnosed really early as a baby, and they were on a phytanic acid restricted diet since then, and therefore they don't have retinitis pigmentosa, although they do have some bony abnormalities. Whether that's related to Refsum's or not, we're not sure, because the bony abnormalities are actually a lot more severe than we see in our patients with Refsum's disease. And I am aware of another patient elsewhere who also has quite severe bony abnormalities. And therefore, I guess as more patients get diagnosed, we will understand the natural history a bit better. And what's important is a community like yours, where patients are registering their details and their phenotypes so that we learn from that and from each other, really.
Yeah, I know in your clinic in particular, obviously, since you have the largest cohort of patients, you do have a lot of siblings who have been diagnosed. And would you, in general, have you seen where the older sibling who gets diagnosed first, let's say they present earlier, they get their diagnosis, and then the younger siblings, get diagnosed through genetic testing, that they have a better prognosis, as far as their symptoms and things?
Yeah. So apart from, so a lot of the siblings who are there in our clinic are actually an older cohort and therefore would have all had retinitis pigmentosa for a few years before they were diagnosed with adult Refsum disease. So the slightly younger one, as I said, we've got this one sibling pair where there is a definite sort of difference in them not having retinopathy because they were treated early.
Yeah, I guess my thought was that I've been in contact with a couple of folks at your clinic, and siblings, and that where maybe they still have RP, but their progression has been much better in comparison to their older sibling, let's say. And so just wondering obviously one of the things that we continue to say here at Global Dare is that the earlier the diagnosis, the better the quality of life. And so, there really isn't a paper out there today that kind of shows that, so we get challenged. I know that even in the UK, they're now doing genetic testing, for newborn babies, right? And we're not included there because not necessarily there's anything that says that, hey, early diagnosis will actually get you a better outcome. But I think we believe that that's the case, but there's nothing documented, so they don't go based upon just what we think.
Yeah, no, it's true. It is true, and perhaps we should make an effort to write those up, those siblings.
Yeah. Because I think that would be helpful in being able to show that, hey, being on the diet and getting early diagnosis does make a difference. It might not stop the progression of things, but slowing the progression, having your vision for longer or fending off other symptoms is a huge quality of life for individuals. So let's see, do we have any other questions that I missed? I don't think so. So I think we can end here. So I wanted to thank you, Dr. Ramachandran, for, really just coming on here, giving us such a great informative presentation, answering all our questions, which I know, as we talked about earlier, isn't always easy because there's a lot of unknowns with adult Refsum disease, and it's hard. You can't always tell us everything because there's not all the answers are there. So we really appreciate you taking the time and your active, continued impact on our community by the work that you do at Guy's and St. Thomas for the adult Refsum disease patients that come to your clinic, and also for being on our medical and scientific advisory board and being a strong advocate for us. So you've been with us on this 5-year journey that we've had for Global Dare Foundation right from the beginning, I think even before we got started. So I really appreciate the collaboration and the ongoing work, and very excited for your soon to be hopefully early next year maybe published guidelines on adult Refsum disease for clinical care. So very excited of that. So thank you, and thank you for the participants who came on and asked your good questions. We really appreciate the participation. So I think that ends today's session, and hopefully we have a couple other webinars the rest of the week. So hopefully people will join those as well and participate. But thank you. Have a good day.
Thank you very much. Thank you for having me. Thank you. Bye-bye.